GvHD Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the GvHD Hub podcast. Today we'll be hearing from Zinaida Perić of the University of Zagreb, Croatia, and Bipin Savani of Vanderbilt University Medical Center in Nashville, US.
Hey, good morning, my friends, and good afternoon, Europe. I'm Bipin Savani. I'm one of the faculty at the Vanderbilt University Medical Center, transplant physician. I'm with Dr. Professor Zinaida Perić here. We're going to talk about commonly affected long-term issues after transplantation. And we're specifically going to talk about what should supportive care look like for patients with GvHD, and what the role does physical therapy, physical activity play in this patient population. So let me start with some background information, and we're going to interact each other. As we all know, there is a link between late complication and chronic GvHD, survivorship and late effect and complication of chronic GvHD. As we also know that number of long-term survivors are rapidly rising. More transplant, more survivors, and many of these patients are vulnerable to chronic GvHD-related late effect. And now we need to focus on long-term survivorship. The shorter life expectancy among long-term survivors. Survivors suffer from multiple issues, including quality of life issue. We need to focus on this, and most programs able to manage many of these issues in the late effect or long-term clinic or long-term transplant clinic, follow-up clinic, or GvHD clinic. So we need to start with what goes wrong in next 3 decades after transplantation. What do you think, Professor Perić?
Supportive care is very, I would say, comprehensive. So supportive care is everything besides systemic treatment. So majority of treatment of patients with chronic GvHD is actually supportive care. And there are so many aspects of supportive care that actually we would need a whole day to discuss it. And I would say that I think this is the main problem, that usually the focus is on systemic treatment, and we are not focusing enough on some other aspects. For example, in chronic GvHD, local treatment can be very effective, especially in oral, skin, and eye GvHD, so most affected forms of chronic GvHD. And there also, if you have enough effective local therapy, you can even avoid systemic treatment, because that usually significantly impairs quality of life of patients. And if you avoid systemic treatment, then you can actually avoid some patients dying of infections, which is actually patients who are at 1 year still on immunosuppressive treatment. They usually have a higher rate of infections and even lower survival. So prevention of infections is another aspect of supportive care. Then we have nutrition, then we have physical therapy, then we have psychosocial therapy. So all these components make it very difficult for a hematologist to take care of when there is one patient in front of him. So therefore, it is the most important thing, I think, in supportive care and in management long-term and chronic GvHD patients is the multidisciplinary approach, because chronic GvHD is a multisystemic disorder. It affects any organ, and hematologist is a blood doctor. Although they're very smart, they're not that effective when you have to take care of all this. So I think the real key to the management of all these patients is to have organ specialists who meet and discuss the patient and evaluate the patient systematically, and then actually try to find ways to treat the patient with at least immunosuppression as possible. And if you want to say like that, maybe the most supportive care, because this is really something that will improve quality of life and maybe prevent some complications.
Yeah, I fully agree. Non-transplant team is very important to long-term care of long-term survivors, especially those with chronic GvHD related post-transplant complication. So I fully agree. We do have best pharmacological intervention ever than before for chronic GvHD. We have now 3 approved drugs. We have ibrutinib approved in 2017, and then we have ruxolitinib approved in 2021. Again, same year we had early approved belumosudil approved for. But also at the same time, we do have a best documentation of chronic GvHD because of regulatory requirement and other requirement. We do have lots of ongoing clinical trial for chronic GvHD. At the same time, nowadays, we have the best supportive management for the patient with chronic GvHD to support them. And again, among all the symptoms, major problem is physical symptoms. So what are the prevalent physical symptoms? Let me start with here. Pain. Most pain is correlated with active chronic GvHD, like arthalgia, myalgia, muscle cramp, predominant pain symptom. And second most is fatigue. Fatigue is among the most common concern among transplant survivors. As we know, moderate to severe fatigue is in about 50% of survivors, even after 5 years after transplantation. And then third and most relevant is reduced sleep quality and reduced sleep quantity, which contribute to poor quality of life and fatigue. In addition, sexual dysfunction and sexual dissatisfaction are common, add to the ongoing issue. So what I can say is one of the major complications is physical dysfunction, physical symptoms, which are related to all those manifestations. So how can we help our patient in addition to targeted pharmacological intervention?
I agree, Bipin, with you. This is a big problem. And basically what can improve physical functioning is basically physical exercise and physical therapy. So these are the main two, I think, are ways to help our patients. The problem is that even though the NIH consensus, the German, Austrian, Swiss consortium, they all say that this is important. And in NIH, physical therapy and physical exercise is grade A3 recommendation. These recommendations are general. We do not really know what that means. And if you look at the data that we have mostly data on transplant in general, so physical exercise before, during, after transplant, for example, but not specifically in chronic GvHD, and not specifically, especially in sclerotic GvHD, because sclerotic GvHD is an entity where you can do the most with physical exercise and physical therapy. So we know intuitively that it works, but we don't know when to do it, how to do it, when to start, how long to do it. I would say that in recent times there has been a bigger awareness of that. There are several studies or even reviews, meta-analysis of randomized trials that we have in physical therapy, and there is, I would say, moderate to high evidence for physical therapy and maybe moderate evidence for physical exercise if it's home-based for chronic GvHD. But there is a higher awareness, and there is I think we should mention a recent review of rehabilitation interventions in sclerotic GvHD that has been, I would say, published last year in 2021 from Dr. Moles Poveda and the co-authors. And this is a really nice review where you can see well, first of all, it's based mostly on sclerotic GvHD, but at least you can here see everything that we have, all the data that we have. So it's basically several cases and case series, but also there is a review of all possible interventions treatments that can be done in patients with sclerotic GvHD. So not only physical therapy and physical exercise, but also some of interventions that are used in other sclerotic diseases. Or also there's occupational therapy, because patients with sclerotic GvHD have sometimes problems with activities of daily living. Sometimes they have problems with speech as well, and eating. So there are also those speech and language specialists that can be involved. So this is, I think, a great overview of what we know so far and what are the future directions in physical therapy. But I mean, basically physical exercise and or physical therapy, physical therapy interventions and physical exercise should be started as early as possible, of course. But for example, in sclerotic GvHD, we also have to have in mind that extensive physical exercise and stretching can actually provoke fibrosis. So we have to be careful there. But I would say, so physical exercise, physical therapy, and occupational therapy. That should be our goal. So all these modalities. And I don't have the best advice on how to do it, unfortunately. Maybe you do, because you have a great long-term clinic.
No. As you all know, as you know, I'm not a physical therapist, so I'm not going to mention technical aspect of physical exercise, but I fully agree with you. But in short, I can say that data on physical exercise is all over the place, although it is recommended by most. And that's probably the reason, because data are all over the place. Our patients are not addicted to exercise compared to pharmacological addiction. I'm sure we all aware about BMT-CT and 0902 study. Exercise, quality of life in transplant patient. Major limitation of the study was were self-directed intervention and low intensity. And same issue in most study. Overall, to me, BMT-CT study dampened the enthusiasm for exercise-based intervention during transplant. However, study result directed us to focus on targeted intervention. So let me tell you what we do in our program. Most of our patients are referred to Vanderbilt University Center for Health and Wellness. It's a rehab program. First physical exercise evaluation around day 30 post-transplant, all patient, all allo, after engraftment, and if there is no active infection, like active infection issue or active GvHD issue. Initially, more frequently, like 3 times a week, 2 times a week, and then once a week, and then every other week, depending on their need. And initially supervised, fully supervised, then partially supervised, and then unsupervised. You know, this is the best way to get addicted to the exercise program, and it works based on our experience. And so in summary, I would say no doubt we have lots of pharmacological intervention, but physical activity, physical dysfunction is a very prevalent symptom, affect the quality of life even beyond 5 year, 10 year post-transplant. And it is still very challenging to provide best supportive care in patients with chronic GvHD. Supportive care intervention is the utmost priority to me. What do you think, Dr. Perić?
I absolutely agree, and we should aim in maybe connecting more physical therapy specialists and experts, and connecting them, especially the ones who are taking care of patients with chronic GvHD, in order to provide us also with some guidance what to do and how to advise these patients, because it's not so easy if you don't have a dedicated program like you have in your clinic. Then it's not really easy to advise patients on what exactly should they do, especially, for example, in sclerotic GvHD, and not to overdo it, for example. But but it is true that patients intuitively, if they're tired, if they feel fatigue, they rest. So they are not going to go and exercise. And when they rest, their muscles are wasting, and they're feeling more and more tired. So it's like a vicious circle. So definitely we have to tell them, you are maybe tired, but the solution is not to rest. You have to exercise to be less tired.
Yeah, I agree with you. And thank you very much, Dr. Perić. This was an exciting discussion and the best for our patient. Thank you.
Thank you, Bipin.
Thank you for listening to the GvHD Hub podcast. We would also like to thank our supporters, Insight, Novartis and Syndax.
GvHD Hub podcasts, brought to you by Scientific Education Support.